3 times more women than men are affected by MS, so living with MS and having symptoms of menopause can be difficult for many. On Wednesday the 18th of October, it was World Menopause Day, and we held a Menopause Café here at Revive. We had Professor Ruth Dobson from the Queen Mary Hospital in London discussing that very subject. We recorded that talk to allow us to share it with the MS community. If you're looking for any information or advice with living with MS and menopause, please feel free to reach us at Revive. You can contact myself, Julie Dock, at Revive MS Support at www.revivemssupport.org.uk. Enjoy the video.
So as Julie said, it's World Menopause Day, and we thought what better day to do a talk about MS and menopause. And it's an area that I've become increasingly interested in because there's very little evidence. So it's sort of, I'm going to run through some of the stuff that there is. I've seen some of the questions that have been raised in advance. I mean, as Julie says, there are no wrong questions, there are no silly questions in this talk at all. And actually, I think, you know, all the questions that I get really reflect some of the gaps that we're trying to fill in terms of the evidence. So, as I think probably everybody in this room is aware of, MS is increasingly common in women. The sex ratio, so the proportion of women who are diagnosed with MS compared to the proportion of men who are diagnosed with MS is just going up and up and up. And we see this across different countries. We predominantly see this across relapsing MS, a bit less so in progressive MS. And it's probably due to a lot of things. It's probably due to the fact that our healthcare systems have changed. If you look at the bottom of the graph, it goes right from the 1930s to the present day. And I think, you know, we're all aware that how we access healthcare, how healthcare is spoken about, all of those things have changed quite a lot over the past 100 years. And also we're getting better at diagnosing MS earlier. And partly this is driven by disease modifying therapies. So because now we can do something to treat MS, we're more likely to diagnose it, we're more likely to diagnose it earlier. There's a reason to diagnose somebody. So I think there's lots of things that feed into this, but the end result of this is that we have a lot more women who are being diagnosed with MS than men at the moment. And this is one of my favourite slides, and the more I look at this slide, the more it kind of resonates, I think. And as women, you know, there are different ages of women and things change during life. That's not saying that's not true of men, but I think particularly with women, you have this very distinct, almost periods of life, going from childhood right through to the right-hand side of the picture, which is where I feel like I am at the moment with my very sad cat sitting beside me. But it really is an evolution over time, and this brings particular challenges. This brings particular different aspects to treating people with a chronic lifelong disease. As we all know, we can't cure MS. MS, once you've been diagnosed with MS, you have MS for the rest of your life. It's something that you live with, and something that can change or adapt during different phases of life, and may sort of enact differently during different stages of life. But given that, you know, 2/3, 3/4 of the people we diagnose with MS are female, given that we know very well and have known for many, you know, decades, millennia, that women's health changes during life, surely we have this all sorted now. And I sort of come back to this, there is always hope. There is always hope that one day we will get it sorted, because it's very far from that point at the moment. And this is a really rapidly changing area. We've got so much to learn from other areas of medicine. And I think sometimes as neurologists, as neurology services, we can be quite inward looking and think just about other neurological diseases, but actually thinking about rheumatology, thinking about gastroenterology, thinking about reproductive health, women's health, sexual health. It becomes very apparent that actually there's expertise and excellence everywhere. And this is really starting to develop as a field of both academic study but also practical importance, as commissioning and policy bodies are really recognising the importance of hormonal changes during the female lifespan. And this means that actually people are talking about this more. And I think probably everybody in this room has noticed that over the past 5-10 years, there's been a real increase in discussion and discourse around menopause and around how this is viewed in the public eye, how this is spoken about. And I've got Imi on the call, and some of the work that Imi's been doing, which has been really interesting, is actually looking in the archives of newspapers about how menopause was written about in the papers sort of hundreds of years ago. And she's got some really nice examples about actually how people talk about this has really shifted, and we're now in a time where primetime documentaries with people like Davina about menopause are actually hitting our screens, and it is something that people have a lot more awareness of. Many workplaces have a menopause policy. Now, whether this is a good thing or a bad thing, I think sometimes is a little bit debatable, but it's certainly something that is within people's consciousness to a far greater degree. And this is also being reflected on the research stage. So as Julie said, I'm just back from a big MS conference in Milan. Got back last week, and I was actually chairing a session which was all about menopause. And this is really the first time that this has actually featured on a large scale research stage, discussion about menopause, about what do we do. It was actually featured as a debate, and the title of the debate was "All Women with MS Going Through Menopause Should Go on to HRT." And what was really interesting actually was both of the speakers, so the other two speakers who were on stage with me, gave really eloquent, really evidence-based arguments as to their position, both for and against. And the audience was very, very split. At the beginning, we had a 49%, 51% split. So it was pretty much bang on 50-50 in terms of what people thought. And by the end, it was still very close to 50-50. It was 45-55, showing that there is, where there is this division of views where people really are undecided. I think that speaks to the fact that this is an issue that needs more thought, more study, more work. And why does it need more thought and more study and more work? Well, actually, within MS specifically, there's very little evidence. This is work that was done by some colleagues of mine, really trying to look at women's health in MS and trying to look at what the evidence was. And when I've previously come to Scotland, quite a lot of the time it's been about pregnancy talks. And if you look at this figure, you can see that actually pregnancy is doing pretty well. There's a lot of work out there. There's over 250 papers published around pregnancy. We're really getting much better at treating women during this stage of life. However, come to menopause, and it's about 25. This is really small amounts of papers around this topic that everybody who has periods will go through menopause at some point. This is more inevitable than pregnancy, if you like. It's really important. It happens to everyone, and we're just not looking at it, and we're not looking at it in MS. And this is in real contrast to what we see happening clinically, where there are so many women that come through clinic saying, I'm going through menopause, my MS, my menopause, everything's gone awry, things are really falling apart, I don't know what to do, I don't know what's causing my symptoms. It's a really, and disentangling that is really complex, and we don't, as scientists and as clinicians, have the research, the understanding really to advise what we're talking about. So what I was going to do today was just to run through some of the evidence that we do have, some of the data that we do have, and think about what we can do and where we still need to do better. And so I thought a good point to start would be to say, well, what happens to hormones during menopause, and why might this be relevant to MS? Like, why is this not just a thing outside MS? Why actually is it important to MS? And this is a figure actually that was shown during the debate that I chaired last week, and I think it's really helpful to actually think about. And what happens during menopause is that estradiol, which is the active form of estrogen, really drops off a cliff. You can see this red line here. During reproductive age, it sort of fluctuates on a monthly basis around periods, and then it falls off a cliff around menopause. In contrast to in men, where there's a gradual reduction in testosterone. So it's not to say that there aren't changes in men that are important, but one of the real stark contrasts is this abrupt drop in females compared to males. Males do also get drops in estrogen levels. Women also get drops in testosterone, but these are not quite so sudden and quite so abrupt. And really, it's these very abrupt hormonal changes and fluctuations that appear to cause many of the symptoms that people get with menopause. And this can be really varied, and this is one of the complicated things. It can be really varied within one person over time. It can be very unpredictable, but also women may experience menopause very, very differently. So I suspect, and I'm not going to do this, but I suspect if we went around the room and said, you know, who's been through or going through menopause and what symptoms do you have, we would have a real range of different symptoms, would have a real range of how people have experienced this. And lots of things feed into this, biological things feed into this, sort of your own, you know, personal makeup feeds into this, how you are made. And that's one of the really great things about being an MS clinician, is the fact that everyone's different, but it does make it really challenging when you have, you know, menopause, which is really individual, MS, which is really individual, and then all these changes happening at once. And of course, many of these symptoms can overlap with MS symptoms, but also they can make MS symptoms worse. So hot flushes, which is often the thing that people think of first when they think about menopause. We know that a lot of MS symptoms can be very heat sensitive. So if you get hot, if you go somewhere hot, humid, sweaty, MS symptoms can get worse. And this is, you know, this is true for a lot of people with MS. It's got a really clear biological basis. Our nerves aren't as good as conducting when they're very, very hot. So having hot flushes can actually bring out some of those symptoms. It can make the MS symptoms worse. It can sort of slow our nerve conduction. It can make weakness in the legs worse. It can make other things worse and cause what we call is potential transient worsening. And obviously, if you're having ongoing hot flushes for months or even years, this is not just like a temporary thing that lasts for 10 minutes. This is a major thing that impacts on quality of life over a long period of time. I'll come on to some of the ones that can overlap or mimic MS symptoms on my next slide. But I think the other really complicated thing is actually that it's really difficult to understand what's happening in terms of MS with menopause and what's happening with aging, because for most people, they're really, really linked. You know, there are a small number of people that have premature menopause, who have surgical menopause, but the vast majority of people, menopause is linked to your age. And also MS, you know, the onset can be different. People have their disease for a different age, you know, HRT exposure. So trying to understand all of those things and how they all link together is really complicated. And I mentioned these sort of transient worsening, but the transient worsening that may go on for months or years, understanding whether that causes even longer term changes, sort of over 5 or 10 years, that's a really long time to try and study this. And of course, you know, if you're having worsening that's related to MS, but not your MS getting worse, that's lasting for years, you change what you do so that, and that change may be permanent. So trying to untangle all of this big mess is really hard, and it's really understudied. Because as I mentioned, the menopause symptoms can mimic or worsen MS symptoms as well. And a few of the common ones. So sleep disturbance is really common around menopause. Sleep disturbance is also really common with aging in general across both males and females. And obviously, a lot of people with MS have trouble with sleeping as well, particularly if you've got bladder dysfunction, if you're having to get up in the middle of the night to use the toilet, if you've got pain, if you've got spasms, all of those kind of symptoms. So there's lots of things that can impact on sleep disturbance, both related to MS and related to menopause. And of course then, and I think as probably everybody on this call knows, if you've had one bad night's sleep, you're probably okay. If you've had a run of bad sleep lasting for days, weeks or months, you know, you can't think straight, your cognitive functioning is completely off, your fatigue is completely off, you feel absolutely dreadful. And the sleep is probably contributing to that. But then if you don't know what's causing your sleep to go off, you're sort of stuck in this vicious cycle, and then people start to understandably worry about having poor sleep, and then you can't sleep, and it can become really, really challenging to get on top of. Urinary and sexual dysfunction are obviously common symptoms of MS, but they're also very common during menopause, related to the abrupt loss of estrogen. Many women with MS have urinary and or sexual dysfunction, but the frequency goes up post-menopause, most post-menopausally. And quite commonly in clinic, we see a number of women coming through who say, oh, I've had lots of urine infections. I've had lots of urine infections. They don't seem to get better with antibiotics. We never grow a bug, don't know what it is. And actually that can be menopause. You can get urinary symptoms that really mimic urinary tract infection. It can be related to vaginal dryness. It can be related to changes within the urinary tract. And actually treating menopause with potentially topical treatments can actually really revolutionize things for some women. And then of course mood. So hormonal changes associated with menopause may impact on mood, and I think we're increasingly aware that mood is a major cause of sort of mood disturbance around menopause is a major cause of problems for women. And this occurs at a time of life which is similar to that when many people shift towards sort of from relapsing disease to progressive disease. And obviously that can be quite psychologically challenging, because it brings about sort of questions about the future. It brings about questions around treatment. There's an awful lot going on. And I think often people also feel that they go to their neurology appointments, they say things are gradually getting worse, and the clinicians say, no, your scan's stable, you're fine. And that is in contrast with someone's experience. And that combination of physical and psychological changes can leave many people vulnerable. Oops. So one of the questions to think about, so does MS change around the time of menopause? Is there a change in MS? The simple answer is we don't know. The simple answer is we don't have the answer to that. It is likely that there is this sort of shift towards progressive disease, but is this related to menopause? And I've just put two studies into this bit. This is the first study, and the two studies showed different things. And I think this is a real education in, if one study says something and another study says something different, it means we don't know the answer. So this first study looked at a large number of people. It looked at the EDSS, which is the common disability outcome that we use in MS. It's a measure of disability, and it tried to look at what was somebody's trajectory. So how did disability change before the menopause? How did it change afterwards? And was there what we call an inflection point? Was there a point at which the lines join rather than being a completely straight line? And they found that the line looked completely straight, whether you looked at age or whether you looked at menopause, that things just seemed to continue. And then another study comes out showing exactly the opposite. It shows that actually there does seem to be this inflection point. It does seem that disability increases post-menopausal. Now, I think that with these studies, it's really challenging to interpret. And one of the reasons it's really challenging to interpret is that the way both these studies did their statistics is they assumed that everybody just continues to move up the EDSS at a fixed rate. But we know that with the EDSS and how we measure disability, people don't move up the scale in an even manner. So, for example, the move from an EDSS of 5.5 to 6 means going from walking independently to using a stick, whereas the move from 1 to 1.5 is the difference between no symptoms and tingling in the hand. And the time it takes for any one person to move between those two things is and can be very, very different. So I think we haven't done the right kind of studies to look at this at the moment. We haven't really got our measures right to understand this properly. And we know that MS is far more than just walking disability or just sort of medical symptoms that neurologists examine people for. So we need to do better studies. We need to actually look at this in terms of the symptoms that people have, in terms of the symptoms that have effects on quality of life, in terms of things that people tell us about in clinic, like cognitive fog, cognitive function. So So my feeling is that the jury's still out on this, and that the reason that we don't know is because we haven't done the right kind of studies. And then the next question that often comes up is, well, you know, if there is a change in MS around menopause, will HRT stop this from happening? And this was really the basis of the debate. And the person who said no was a professor of neurology from Denmark. And her argument, which I thought was actually quite convincing, was that actually we don't have the numbers to really be able to answer this question. We're actually not even at the point where we have the numbers. And this was some of her data. So this is Danish data. And what they did is they looked at everybody with MS. They've got really good medical records that are used for research, that everybody with MS. And then they matched them up to see if they'd ever had HRT or not. And what they found was that only about 3%, so only about 3 in 100 people with MS, 3 in 100 women, sorry, with MS at any one time were on HRT. That's a really small proportion. And there are lots of things that might influence whether somebody goes on HRT. Their symptoms related to their MS or menopause, their level of disability. People with higher disability may find it harder to access to HRT. Their level of MS disease activity may influence how able they are to get HRT. And actually, when it's only 3 in 100 women with MS who are even getting HRT, you can't really study this properly. You actually need to do studies maybe where you give HRT to people and encourage people to take HRT and look to see what happens, and give people a placebo and see what happens. And there are a small number of studies trying to do this. So there's a small number of studies that look at giving estrogen, which is thought to be the main active treatment in HRT, giving estrogen to women with MS to see what happens to their MS, to see if this has an effect on their MS severity, on what we see on MRI. And I was just going to talk through a couple of those. So the first of those was where they used glatiramer acetate, so that's Copaxone, so that's an injectable therapy we use for MS. So everybody's on an MS treatment. And then they gave some of them estrogen, the kind of estrogen that's in HRT, estriol, and some people didn't get estrogen. And what they found was that the number of relapses was lower in those women who got estriol. So it was lower in the number. It was lower in the people who got the estrogen. And the conclusion from this study, it was quite a small study, was that actually we need to do some more studies. This study shows that a bigger study is worth doing. There was also a second study, and this wasn't in menopausal women. This was actually in premenopausal women, but they used oral contraceptives, which again work by having very high levels of estrogen to mimic the pregnancy state. And again, these people were on interferon beta, on another injectable therapy. And they found that people in low dose estrogens had a bit less disease activity, and those on high dose estrogens had even less disease activity. So there seemed to be some kind of dose-dependent effect of taking estrogens, and that the group taking high-dose estrogens was significantly different from the group who got no estrogens. Again, it's a small study. You've got about 50 in each group, so it's quite small. And but this starts to tell the story that there does seem to be something about estrogen that works in a similar way to disease-modifying therapy. This mainly looked at MRI outcomes. It mainly looked at MS lesions that we see in the brain. There was a suggestion that there might be a bit of an effect on cognition of estrogens, but I think the numbers really aren't big enough to be definite about this. And then the third study that I wanted to flag was one that's recently published by a collaborator from the States, looking at targeted hormonal therapy for menopausal women with MS. And they randomized people to receiving this hormonal therapy or not. And they tried to look at both MS quality of life outcomes and also menopausal symptoms. So also hot flushes were their first outcome. And they found that this did appear to have an effect on quality of life. But really the thing that I wanted to flag was their second point, which is that enrolment was protracted. And this has been the case with all of the estrogen studies, that these studies that use estrogens to either try to treat MS or to try to treat MS symptoms, MS disease activity, or even to treat other symptoms that may impact on quality of life, all of them have really, really struggled to recruit. And actually the first study that I showed, the estriol and glatiramer one, stopped recruiting early because they couldn't get enough people in. And their subsequent study had to close early because they couldn't get enough people in. And I think this reflects that there are real concerns about the use of estrogen. And I think we all know that HRT is not all positive. And this sort of demonstrates some of what might be underlying this Danish data, with only 3% of people getting HRT, that actually there is a lot of reservation and a lot of concern around the safety of estrogens, about the safety of hormonal therapy, about the safety of receiving high dose hormones. And I think that represents a real challenge. And I think that it's something that as researchers and as clinicians, we really need to think about. We need to think about how we talk with people with MS, people living with MS, to understand how best to design these studies that appreciates these concerns, takes these concerns on board, and design a study in a way that people feel comfortable with. Because there are actually positive things about estrogens outside of MS, outside of sort of direct inflammation in MS. And increasingly, certainly I and also a lot of my colleagues, we think of MS as a whole body disease. It's not just lesions in the brain, it's a whole body disease. And it's when we look at UK Biobank, which is a large population study, and we look at frailty and pre-frailty, which is a sort of global measure of how robust people are, for want of a better term. Actually, we see MS as a leading cause of frailty in middle-aged, sort of older middle-aged people. And how do we define frailty? What goes into frailty? Things like weight loss over the past year, exhaustion, decreasing physical activity, slower walking speed, slower grip strength, more muscle weakness. So there's lots of things that sit there and ring very true with people who have MS, particularly as people might get older, that actually these symptoms may make them a bit more frail. And actually this is the effects of MS on the whole body, not just on the nervous system. And this goes back to some work that I actually did quite a long time ago, sort of 10 plus years ago, thinking about fractures in MS, because fractures are a real problem in MS. They're a real problem postmenopausally as well. And we know that one of the big reasons to go onto HRT is actually fracture prevention. So people with MS have higher rates of self-reported fracture. This kind of makes sense on one level. If you've got MS, you're more likely to fall, particularly if you have sort of difficulty walking. And the more you fall, the more likely you are to get a fracture. That's true of anybody, MS or not. People that fall over a lot are just more likely to get a fracture. They have more opportunity to. And also the association of MS with low vitamin D. People may not be weight bearing as much. They may lose some of the protective factors against fracture. And of course, in a female preponderant disease as well, postmenopausally, people are at increased risk of fractures. And HRT is actually protective against fractures, and that's been shown in a number of studies. And so maybe we should be, again, coming back to MS as a whole body disease and thinking HRT, actually, it's not just about menopausal symptoms, it's actually about protecting bone health, particularly in people who've maybe lived with MS for a long time, who are having falls and who have low bone mineral density anyway. And I do think that with advances in HRT over the past few years, we actually have this ideal opportunity to offer personalised healthcare. Now, that's very different from saying everybody should go on HRT. It's a very, very different statement. It's saying that we need to think about HRT in the same way that we think about other symptomatic therapies. And I borrowed this chart from elsewhere, but it shows the range of complexity around HRT now. There are patches, there are gels, there are estrogens, there are progesterones, there are different forms. And, it is very much not a one size fits all. And I think previously, when people have thought about risks of HRT in the early HRT studies, very much have been a one size fits all. But it may be actually that we can chip away at some of these symptoms with topical HRT preparations that don't expose people to the range of risks that have previously been documented. I don't think this is necessarily where MS physicians should be doing, saying, oh, you need this kind of HRT. But I do think it's down to MS neurologists to also open up those discussions, because certainly we've seen quite a lot of hesitancy around GPs not wanting to get things wrong, not wanting to prescribe HRT and MS for sort of historical reasons. And actually MS teams just being able to say, no, it's fine. MS is not a reason not to get this. You need to have these discussions as if you were somebody not with MS. And really that's the role of the MS team. Because as I said, the risks, much of the data comes from early HRT. There's concerns around stroke and cancers, particularly breast and gynecological cancers. And the approaches to minimise risks are still under consideration and being, you know, worked out in a lot of detail by people that know a lot more about HRT than I do. And balancing those risks and benefits is complex. And this really is where it comes down to individual personalised medicine. You know, do you restrict time on treatment? That was what one of the Americans said to me. I'm not sure that's right for everyone. Do we think about how HRT is given? That's what some HRT providers say. How do we manage to personalise those risks? Because it isn't all down to the MS team, but they do play a really important role. And I think as I sort of start to sum up what my argument around menopause is actually that we have a set of eminently treatable symptoms. Many of the symptoms associated with menopause, we know how to treat them. We know that HRT is the treatment. That's not saying HRT is free of risk. It's not saying HRT is suitable for everyone, but it's taking a very symptom-based approach. And the evidence for treating those symptoms is far stronger than a lot of the symptomatic treatments we currently use. As neurologists, we use a whole load of treatments for people's symptoms where the evidence is often not the greatest. HRT actually has really good evidence, but understanding which symptoms relate to MS and which might relate to menopause can be impossible. It can be so difficult to disentangle as to be impossible. And sometimes it really is a case of trying a treatment and seeing if things improve. And I think as a clinician, you know, my one message around treating MS and menopause is actually that you have to be a bit humble. Sometimes say, I don't know. Let's try one way of treating this, see what happens. If it doesn't work, here's a plan B, here's a plan C. You know, there is trial and error. Everyone is different. And we are gradually getting pieces of the jigsaw together. So we are gradually managing to build together a picture of how MS and menopause might interact. And there's some really exciting work going on in the States, sort of looking at atrophy, looking at whether, you know, when do you give estrogen? How should you give estrogen? Does this affect atrophy? Does this affect, you know, brain shrinkage? Does this affect what's going on in the brains of people? And they're doing some really neat work as well, working towards a clinical trial that I think is just about to open, actually looking at brain shrinkage in very specific parts of the brain, which they think they might be able to prevent with estrogen. So I think, you know, we're getting pieces of the jigsaw. We're a lot further than we were 5 years ago, but we've still got a long way to go. And for the last few slides, I just wanted to hand over to Imi to introduce herself as a bit of a plug for what she's doing. So Imi, I'll do the slides if you want to talk.
Thank you. Hopefully everyone can see me or at least hear me. But yeah, thank you, Ruth, and thank you everybody for giving me a couple of minutes just to plug the study that I'm doing. But I'm Imogen, I'm one of Ruth's PhD students, and I'm researching how women with MS experience menopause. So very much looking at sort of personal experiences and what people do to manage MS and menopause when they're kind of happening at the same time. And one of the ways I'm doing this is by running some interviews and focus groups with women with MS to ask them sort of directly to tell me about their experiences. Could I have the next slide, please, Ruth? Thank you. So this study was designed with, I've got a really brilliant kind of advisory group of women with MS who helped me to come up with the best way to run the interviews and focus groups. And really, they kind of just impressed on me how important it is to give people a lot of choice about how to take part in this. So you can choose whether you would prefer to take part in an individual interview with me or in a focus group with sort of 3 to 4 other women with MS. You can choose whether you'd like to take part virtually, so over the phone or via video call. That's sort of to give access to people living throughout the UK as well. So it's not just a very London focused thing. Or face-to-face if you would prefer, and if you would prefer to travel down to London and take part face-to-face, we'll pay your travel expenses and travel expenses for a supporter as well if you want or need to bring somebody with you. And we offer £25 voucher for every hour spent taking part. So for an interview, that's going to be around about an hour. For a focus group, it'll be about 2 hours with a break in the middle as well. Could I have next slide, please, Ruth? And this is who can take part. So if you would like to take part and you live in the UK, you're over 18 or 18, you identify as a woman, you have a diagnosis of MS from a doctor, and you know or think you might be perimenopausal or postmenopausal, then you're eligible to take part if you'd like to. There's really no wrong experience, so you can have experienced menopause at any age, and you can have had surgical or medical menopause as well as the sort of more common age-related menopause. And the last slide, please, Ruth. And these are my contact details. So if you would like to take part, or if you're just interested in finding out a bit more and have some questions at this point, you can email me, ring me, text me, whatever you prefer, or go to this web address at the bottom, and that's just got a link to where you can leave your contact details and I'll call you or email you, whatever you prefer, to give you a bit more information. I know this will go on YouTube, but is there a way of possibly sending that slide around to everybody so they have the contact details?
Yeah, I can give that information out, Imogen.
Brilliant.
If what's it? Yeah.
Excellent. Thank you very much.
I'll take a wee picture. Thank you so much. I'll take a wee picture of your slide here. Thank you.
All right. I was just hang on. I've got one more slide.
Have you? Yeah.
So, and then I'm gonna ask if anybody's got questions. I'll stop sharing. So, I mean, just before we sort of go into questions, just to say most people with MS are female, but menopause is understudied. And we need to think about all the ways that this might, that we need to talk about this, that we need to think about how this impacts on people. And menopause treatment symptoms are treatable. And I think actually that's the key thing, isn't it? Even if uncertainty remains about the impact on MS, we've got symptoms that we can treat. So that's it. So I'm going to open for questions. I'm going to stop sharing so that I can actually see what's going on. Hang on.
Yeah.
There we go. I can see you now.
I'll turn you around to me so it's my face you see. But I'll ask questions. So has anybody got any questions for Ruth or Imogen that you'd like me to ask? The question was that someone has previously, well, they've stopped having a period for a good number of months, thinking that that was them coming to an end, and all of a sudden it's just came back. Is that common to happen?
So it depends. I mean, so if you've been without a period for 12 months and you've got a period back, that's called postmenopausal bleeding, and that's actually where you should see your GP about that, because the answer is it can be normal, and I think periods can be really erratic during menopause. But if you've had a long time of not having period and then you get one, it's a good idea just to get checked out, just to make sure it is that kind of normal menopausal sort of periods being erratic rather than something else going on.
Yeah, so she says you're not too worried just now. It's about 3 or 4 months.
Yeah, so that can be really normal. That kind of like people having really regular cycles for like their whole adult life, and then suddenly like having 6 weeks, 2 months, 3 months between periods, and having sort of very heavy periods when they do come is often part of menopause. And it's that, again, it's that unpredictability which can be really challenging, like especially if you're used to periods being really regular and then suddenly it's all gone completely awry.
Yeah.
And they can, some people find they can be very light, some people find they can be very heavy and very long, and it is that unpredictability. And again, sort of from the MS perspective, that can really impact on your MS as well. If you're having a really grim, long, heavy period, actually that's going to make everything feel worse. That's going to, that can really impact on your fatigue. It can really impact on your sleep. It can really impact on a lot of the symptoms that you're having. And if you're having lots of you know, and some people find they can have sort of the very long, heavy periods and can become quite anemic with them. So if that's happening, you know, it is sometimes worth getting a blood count check, because actually we do see that people can get quite anemic during this time where things have been okay when they've been predictable, but then suddenly it all goes wrong.
So, lady here, 56, not had a period for 8 years, now starting to experience menopause symptoms, being told by her, was it GP? The GP that she is now going through the menopause.
Yeah.
Wasn't.
So this is one of the challenges, isn't it? And I think sort of to answer a slightly different question first, and I will come back to that question, is that, you know, we now increasingly see that people use forms of contraception that stop them from having periods and may not know when they kind of naturally stop having periods, because they sort of don't have periods because of the coil that they're using or because of the hormonal contraception. But what we do increasingly recognize is that sort of menopause is not one point in life. It's sort of, I hate the word a journey. I hate calling it a journey, but it is kind of a journey. You know, and 8 years after having your last period feels like quite a long time, and I'm not a sort of menopause outside MS expert, but you know, you are kind of, that hormonal change does take years. It's not something that happens overnight.
Yeah, so basically you've been going through menopause a lot longer than
it can be. You know, some people do
controlled.
find it's a really protracted, long process and doesn't follow a kind of neat map.
Yeah, because you can go through menopause in your early 40s.
You can go through menopause in your early 40s. Yeah, you can go through menopause in your early 40s, but there's lots of things that kind of impinge on those symptoms that people get from it as well. It's not just the kind of stopping periods that impinges on those symptoms, I don't think.
Yeah, yeah. Thank you. Any other questions? Yeah. With my menopause brain, I'll try and remember all that.
It's all right. I heard that question. Sometimes it cuts out, but sometimes it does.
So
do things get better?
Do things get better? Because the problem that she was experiencing was thermoregulation in her body, but now that seems to have settled down. But being on the Mirena coil for many years, not having a period, wasn't actually sure where she is on her journey with menopause. So can things improve during this period?
Yeah, absolutely, things can improve. And again, I'm sort of going to borrow from non-MS to migraine, actually, which is something that we know a bit more about, the sort of hormonal fluctuations and how that impacts on disease. So migraine, I expect everybody in this room knows what I mean by migraine, kind of migraine headaches. And we know that lots of people, lots of women particularly, have migraine that's associated with hormones. And what we see that's really interesting with migraine is that some people, it gets much worse during menopause and then it settles. Other people, it just vanishes at menopause completely. It can be really variable. And there's no reason to think that MS is any different, actually, that, you know, it's really individual, and hormones probably do play a part in how people experience their symptoms for quite a lot of people. And I think, you know, even people who have the Mirena coil still get hormonal fluctuations during the month, even though they don't bleed. And often people do say, oh, well, I feel like things are much worse sort of, you know, around the time my period would be due. I know when it would be due. I get some symptoms, even if I don't bleed. And, you know, there's no reason to think that actually for some people, estrogen's driving some of their symptoms. And actually when that drops, you feel a bit better. So it's the thing is, it's totally plausible. I think we all focus on menopause being this awful thing where things get worse. I'll have to send you, Julie. It's really inappropriate, but it's so funny. There is a Simpsons short thing about menopause, that's all about sort of it being a positive thing. And it's just very, very funny. But I will email it to you, and you can show everybody if you wish.
Yeah, I will.
2 minutes long. But
so menopause could actually be as individual as like MS itself being individual.
Exactly. I don't think it's like it can be. I think it is actually as individual. And I think that's one of the challenges sometimes with things like documentaries and the way that people talk about things. They talk about, well, you need to have this treatment because it will make everything better. Well, actually, that's not the case for everyone. For some people, they don't need the treatment. You know, actually things are fine. And I think as I'm sure many people in the room have experienced, for everyone that really struggles with menopause symptoms, you'll find somebody else who says, well, I was fine.
Yeah.
What's all the fuss about? I was fine. So I think it is something that's very, very individual. And we see that with MS as well, as everyone knows. Some people have a really torrid time with particular symptoms. Other people just breeze through. And we can't explain why that is.
No.
Other than we're all people, we're all humans.
That's really interesting. Well, thank you. Yes. Did you hear all that?
I did hear all that, and I think that kind of story is not that uncommon, where people have really struggled to access sort of healthcare treatment, because sometimes the rules are quite rigid around sort of age cut-offs and things like that, which work if you look at a sort of whole population, but don't necessarily work for individual people. And I think that lots of people are finding they're sort of having to advocate for themselves around treatment, and I think, you know, what we hear a lot of in clinic is people saying, oh, well, everybody said no until I found X GP or Y GP or somebody who listened. And I think, you know, what I do think one of the reasons for talking about is more having these discussions, sort of understand the range of ways that these things, that menopause impacts people, the sort of overlap with MS, those kind of things, is actually just to try and start talking about this a bit more. And some of the work we're doing, it's slightly less relevant to Scotland because it's with NHS England, but is actually to try and develop some cool toolkits for GPs around MS and menopause. And even if we can just sort of start some of those discussions, start some of that awareness, that's actually a really good first step. Because I think sometimes some of the sort of almost computer says no response comes when people just aren't quite sure, and you've got 7 minutes for your consultation and this is actually quite complicated, I'm not quite sure, so I'm just gonna push it for now.
Yeah.
And I think that does happen sometimes.
Yeah, it can be a difficult conversation. It's getting the right GP, isn't it? Yeah.
It is, and then that becomes really hard for the GPs who do it as well. And I think it's the same sort of one of the questions, very provocative question I got asked at ECTRIMS was, you know, should it only be female neurologists running MS menopause clinics, or is it everyone?
Yeah.
You know, and it can be really hard, because I can totally see that it can be really hard to have those discussions, but then you sort of really disempower groups of people, and actually it's about leveling up, not leveling down.
You do, and you can get some really understanding male consultants when it comes to female health. It's just getting the right person. It's not about the right sex of the doctor that you're dealing with. It's getting the right person.
And it also, it's about making sure that where people don't have access to those people, it's not lost.
Yeah,
no,
definitely. No, that's good. So thank you. Any other questions?
Yeah, so I think that sort of firstly I'd say that the sort of situation where your symptoms are, you know, you feel that your MS is getting worse and the MRI says there's no new lesions is not uncommon, and I think that's a real problem that we have in MS care, actually, that the MRI does not tell the whole story, and that, you know, we have this situation where the MRI doesn't tell the whole story, but our treatments are based on what we see on the MRI, and that is a real disconnect, and that is something that is very, very challenging, both for people with MS and also the clinicians, because it sort of it sets things up very badly. I think that has the mini pill masked things? Probably not, actually. I think the effect of the estrogen is very, very small. I think it would be a very small effect of the estrogen, and I think it if it has stopped the lesions, then it, you know, would it have done that over 8 years? Not, I don't think it's that strong. And if it has, then it still has stopped those lesions from happening. But I don't think it would have affected your eligibility for treatment in that way. I think that, you know, what you're describing is something that, as MS clinicians, we really do recognise and are trying to look at quite hard, which is, you know, where this situation where we're not seeing what's happened with the full story on MRI, and what we're trying to do is sort of argue for access to treatment where we see sort of definite changes in people, despite the MRI not telling that story.
Actually, quite leads in quite well to one of the questions that we get posted in the centre that people ask about is HRT and the use of disease modifying therapy for their MS. You know, are they allowed to take HRT for certain medications for their MS? Is that
Yes.
compatible?
So HRT and sort of all the disease modifying therapies are completely compatible with one another. You can be on one, other, or both. They are sort of treating different things. The aim of the disease modifying therapy is for most of them to stop relapses, for a couple of them to stop progression, but mostly to stop relapses. And the HRT is around treating menopausal symptoms. So they're treating different aspects of a person.
Yeah, that's
and
good.
they're safe to use together. That's not a problem.
Good. And another question that's asked a lot, which is probably one we find really difficult to answer, is how can you tell if you're having an MS symptom or is it a menopause symptom?
You can't always. That's the short answer is you can't always. It can be really, really difficult, and they can be the same. And actually, both MS and menopause can contribute to the same symptom, so it can be both. And I think sometimes, to be honest, the only way to tell is to try and treat one of the potential causes, like, use HRT if you think it's more likely to be menopause, or use something else if you think it's more likely to be related to MS, and see what happens. It is unfortunately that sort of pragmatic.
It's really difficult because a lot of the symptoms do cross over. So some people
cross over a lot, and I think particularly with the bladder symptoms, with the sort of sexual dysfunction, with those kind of things, it's often both.
Yeah, and I think it's encouraging people to speak about these symptoms as well, not to be.
It's sort of bringing them up, and I think one of the things that I've discussed with some of my colleagues, it can be really uncomfortable as a clinician to bring up menopause, and even for me, like, it can be really difficult, because then maybe I overthink it, but I think, like, are people going to be judging me, thinking like they're saying I'm of a certain age, or that, so it sort of bringing it up brings quite a lot of emotional sort of overtones or connotations that people do worry about. And I think a lot of my particularly male colleagues worry about getting it wrong. So they don't want to bring it up because they don't want to get it wrong. They don't want the implication of, like, I'm saying you're old, or I'm saying you're sort of, all of those things. So I think they do genuinely often not bring it up because it's just too uncomfortable and they're worried about getting it wrong. So sometimes it does fall on the person with MS to say, could this be menopausal related? And actually just to open that door. But I think the more we get everyone comfortable about talking about these things, and everyone learning the right kind of language to speak about them. So one of the things that one of my colleagues brought up is, even if somebody's not comfortable with it, if you can show that you've got the language as a clinician to talk about this, then that's a really good start. And to be able to say, you may not be comfortable talking about this with me, but you could talk about it with some of these people maybe, and we can try and help
and find a solution.
Yeah,
that's good. Any other questions? So are you aware of any alternative medication, alternative therapies, will I say, for menopause rather than taking medication?
So the drilling has started, so I'm sorry if there's lots of
sorry. she's working in next door.
I've got network on both sides actually of our house. We're in terrace. We've got workmen on both sides, so it's great today. Oh, there we go.
We're just finishing too. This is a nice timing.
I'm just going to wait until they finish and then answer. There we go. Oh, no. There are a range of natural remedies, and there are a range of things that people find help. And there is, again, a sort of degree of, is that going to come through the wall? Sorry. There's a degree of trial and error to this as well, about, like, what might work for one person might not work for someone else. So I think some of it is about actually, again, talking to people, having those conversations, what's worked for someone else. I think anything that's trying to take lots of money away from you is probably a bad idea, but there are lots of sort of natural supplements and things that people do find helpful.
Yeah. So I think on that note, we'll probably end the recording. Ruth, is that okay? So thank you so much. That was really informative, and we got some information hot off the press here from Ectrums, which was really great as well. So thank you. I'll just stop this recording.